Today we have a panel of pharmacists and a physician. Dr. Katie Wallace received her Doctor of Pharmacy from Purdue University College of Pharmacy in West Lafayette, Indiana. She completed a PGY1 pharmacy practice and PGY2 infectious disease specialty residency at Wake Forest Baptist Health in Winston-Salem. She has been an infectious diseases clinical pharmacist at UK Healthcare since 2015 and is the PGY2 infectious disease pharmacy residency program director. Dr. Zachary Porterfield is a physician scientist focused on understanding the interface between viral infection and changes in the lymphoid tissue, the factories that develop and refine antibodies. He obtained his MD and PhD in virology at the University of Oklahoma and completed his internal medicine residency, infectious disease fellowship, and NIH Global Health Fellowship at Yale University. His current bench research focuses on HIV and impairment of immunity at the antibody production level. He has several active clinical research programs in 4 countries focused on improving access to care in remote and at-risk populations through capacity building, local and international collaboration, and task shifting. He splits his time between Lexington, Kentucky, where he runs a lab and consults on the infectious disease service, and Durban, South Africa, where he's an honorary senior lecturer at the University of KwaZulu-Natal and conducts HIV and TB-based research at the Africa Health Research Institute. He is currently a member of several advisory groups responsible for the clinical and research response to the COVID-19 pandemic at the University of Kentucky. Dr. Ryan P. Minat, PharmD, received his Bachelor's of Science degree in chemistry from Morehead State University. He received his Doctor of Pharmacy from the University of Kentucky College of Pharmacy and completed both his postgraduate Year 1 pharmacy practice residency and PGY2 infectious disease residency at the University of Kentucky. Upon graduation, he served as a clinical pharmacist in infectious diseases and antimicrobial stewardship at the Detroit Receiving Hospital, part of the Detroit Medical Center. During this time, he has served as the residency program director for their PGY2 infectious disease pharmacy residency program. He's board certified in pharmacotherapy with added qualifications in infectious disease. Our panelists will give a talk entitled Treatment of COVID-19, a review of experimental therapies and pharmacologic considerations. Please welcome our first speaker, Dr. Wallace.
Okay, perfect. Please let me know if there's any issues along the way. So we'll first be going ahead and talking about the treatment of COVID-19. There we go. So today's speakers have no actual or potential conflicts of interest to disclose. And as most of you are aware, there are no approved therapies for the treatment of COVID-19 proven to be clinically effective through randomized controlled trials at this time. And so this presentation is going to discuss off-label and/or experimental uses of these medications. Here is a list of our objectives for your reference. And to start, I just wanted to acknowledge the impossible balancing act that I think we all feel like we're facing when it comes to making a decision about whether or not to use a therapy. And on one side, we have the potential of giving an agent and then later finding out that there is no benefit, and potentially even worse, the possibility of causing patient harm. And then contrasting that with something that I think feels much more acute to us, which is not giving an agent and then later finding on that there could have been a benefit. And this can be difficult, especially when we're looking at a patient who is critically ill, when ultimately what we may end up finding out is that optimal symptomatic management was really the best that we could offer. So if we take a look at navigating the data, there's a number of questions that we can ask ourselves to try and help us answer the questions about how best to balance what to do for our patients. And the first question that we're having to look at is there any data for this? And then following that can the data even be trusted? And I don't know about you guys, but this is something that I've certainly had to face a lot more than I ever thought I would in my clinical career, which is, making sure that the links to different articles and news media outlets are providing information that we can trust. And then the next is the article peer reviewed? So a lot of these publications are occurring in non-peer reviewed journals. And then next is the usual question that we should always ask, which is the article methodologically sound? So are the results supported by the methods that are described? And then lastly, how should the results be applied to practice? And of course, we're having to try to answer all of these questions within the context of the fact that, I apologize for the animations, this is a pandemic, so we must make the best decisions that we can with the information that we have today. And with this, we have to assess the risks versus benefits for each and every patient. Looking at the pharmacologic targets in COVID-19 that the data is predominantly looking at, we see that there are targets specifically within the virus that are involved in the mechanism of action, as well as trying to target the overwhelming inflammatory response. There was a great visual published out of JAMA as recently as April 13th. And here you can see a demonstration of where these different agents are targeting. And in general, there's really three different mechanisms. One is trying to inhibit the entry of the virus into the host cell. And this is usually by blocking either the ACE2 receptor or the TMPRSS2 receptor. And then there's also the attempt to just prevent viral replication in general. And then lastly, of course, trying to block the inflammatory response that can be seen with this virus. When looking at just general pharmacologic considerations, I thought Dr. Moorhead did a great job last week talking about a number of these and providing the why. And so I'll just provide just the general information for the sake of time. But in general, the CDC and WHO are recommending against the use of corticosteroids unless indicated for specific reasons such as COPD or septic shock. And the FDA does not advise against the use of ibuprofen and other NSAIDs. There was some concern that this could cause exacerbation of the illness. But as with most situations, it's always optimal to try and consider use of acetaminophen first line when able. And then lastly, ACE inhibitors and ARBs should be continued and prescribed according to guidelines per the European and American Societies of Cardiology. And I think the thought process behind this and the mechanism is extremely interesting, but this is a great example of really where the media kind of got a hold of a hypothesis and then caused some uncertainty despite lack of clinical evidence. And so it continues to just point to the importance of not allowing theoretical benefits or harms to dictate prescribing when we know that these agents have a definite benefit in other disease states. So next we'll go into the quinine derivatives. And honestly, I could probably spend a whole hour talking about both hydroxychloroquine and chloroquine, but we're really just going to try to stay focused on what the data is showing us today. When looking at the mechanism of action of these agents, they are thought to increase the pH of cytoplasmic vesicles. And this increase in pH causes dysfunction in several of the enzymes needed for viral replication. And also, it has anti-inflammatory processes that inhibit production of cytokines and chemokines. So a very multifactorial mechanism of action. When looking at the dosing and monitoring recommendations for this drug, there are a lot of dosing options proposed. I've provided here the one that you can see in our pharmacotherapy guidance document. And due to its long half-life, it does allow for daily dosing. And in terms of monitoring, this drug can cause some hepatotoxicity as well as hematologic side effects. And so a baseline CBC as well as CMP is recommended. And due to the ability to cause QTc prolongation, we do recommend getting an EKG at baseline and daily, especially while inpatient. There is no need, though, to check a G6PD. And there are other warnings associated with this medication to be aware of, but the biggest adverse effect is really more GI related. Looking at contraindications, we try to avoid this medication in patients with a prolonged QTc, if they have a hypersensitivity reaction, and also in the presence of visual or retinal changes, although these short courses aren't thought to cause many visual issues. And of course, always keeping in mind drug interactions, so interactions with other QT prolonging meds and also with antacids are important to keep in mind. So let's dive in then to the information that we have regarding hydroxychloroquine and the chloroquine information timeline. And I apologize, the animation might be a little bit off here, but it really all starts in February 19th when Gao and colleagues published basically a letter reporting that chloroquine showed efficacy in 100 patients compared to the control group. And there actually wasn't any data provided with these results, just information related to the fact that they saw that there was decreased exacerbation of pneumonia, quicker time to virologic clearance, and also a decrease in the amount of symptoms. And really from here on out is when the emotional roller coaster of hydroxychloroquine started, with information kind of coming in left and right, which is why asking ourselves those data questions is so important. So following this, on March 9th, Yao and colleagues looked at an in vitro comparison of hydroxychloroquine versus chloroquine in clinical infectious diseases. And they found that hydroxychloroquine was more effective against COVID-19. And then they took the chloroquine dosing recommendation from Gao of 500 milligrams twice a day, and then did different modeling doses of hydroxychloroquine and identified the dose that you tend to see in institutional guidelines as the one that was recommended. On March 17th, though, is really when a lot of the hype for this medication came about. And this was in the Gautret article out of France, looking at hydroxychloroquine plus azithromycin versus placebo. And we will talk in detail about some of these studies just to provide a better background. Following this, on March 19th was when President Trump made his statement about hydroxychloroquine use. And then we see a variety of other studies that got published over the next few days, including another one by Gautret that was just an observational analysis looking at patients who received hydroxychloroquine and azithromycin that was posted on the internet. On 3/28, the FDA issued an emergency use authorization. And then in the next days following is when we see more and more articles coming out about this drug, often in non-peer-reviewed journals. And many of these are being seen in MedRx IV. And actually, there were probably about 5 or so published just between the 10th and the 14th. And so we're really trying to stay on top of this information. So what does this information tell us about the use of hydroxychloroquine? And that's the one I'll be mainly focusing on. And I won't go into all the specific details, but we have looked at these in depth and we'll try to provide them the most meaningful information. So first is the study by Chen and colleagues. And this was actually published before the Gautret study. And it was a randomized controlled pilot study looking at hydroxychloroquine for 5 days compared to a control group just in 30 patients. And they found no difference in virologic clearance or symptom improvement. All patients, though, survived at 2 weeks, so these patients had relatively mild disease. And as is the case with many of these Chinese studies, patients often receive other COVID-19 therapies, including antivirals. And so that needs to be taken into consideration since this is based on their national treatment guideline. And they used oropharyngeal swabs to look at virologic clearance, which we know tend to have a lower sensitivity. Looking at the study by Gautret and colleagues, this was an open label, non-randomized study looking at hydroxychloroquine 3 times a day for 10 days. And this was in 36 patients, comparing it to a control group. And significantly more patients were COVID-19 PCR negative in the hydroxychloroquine group at around 75% versus the control group, which was around 12.5% clearance at day 6. When looking really at the comments surrounding this article, there actually is a lot of information, including in the title, about the combination of hydroxychloroquine with azithromycin. But this was actually only used in 6 of the 20 patients out of the hydroxychloroquine group. 6 in the hydroxychloroquine group were actually excluded for a number of reasons, which can confound the results. There were no clinical or safety results reported, and many were asymptomatic at baseline. And different sites were also utilized for the treatment group versus the control group. And the baseline viral loads in the 2 groups were also different. And so this study really started to increase the thought that hydroxychloroquine might decrease time to virologic clearance, which could decrease the spread to other patients, and we're hopeful that it would be tied to clinical outcomes. Later on, a study by Chen and colleagues, this was a randomized double-blind controlled trial, so a better methodology was published looking at hydroxychloroquine twice a day for 5 days versus a control group in 62 patients. And they found that the hydroxychloroquine group recovered more quickly than the control group when looking at the duration of cough, fever, and pneumonia improvement. But this was not peer-reviewed. Many of the patients received other therapies. No virologic results were provided. And even though there were some statistical differences, when we look at the clinical significance, many of these patients didn't have cough or fever at baseline. So the number analyzed in that final outcome was pretty low, and it was a minimal difference of a day or so between symptom improvement. The next study was actually published on April 14th, and this was a comparative observational study looking at hydroxychloroquine 600 milligrams daily at 4 different sites in France. And the number was higher at 181. And they actually looked at hydroxychloroquine added to the standard of care versus a control group, and did not find a difference in their composite outcome of reducing ICU admissions or deaths 7 days after admission. This also was not peer-reviewed, and fortunately, patients didn't receive other antiviral or anti-inflammatory treatments, unlike in the Chinese studies, but some did receive antibacterials. No virologic data is provided, and although it wasn't randomized, they did try to weight the two groups to account for baseline differences, and then also accounted for the propensity to receive hydroxychloroquine versus not through a multivariable regression. And then lastly, Tang and colleagues also on the 14th published a multi-center open label randomized controlled study looking at a higher dose of hydroxychloroquine for a longer duration of time. And this was in 150 patients. And what they found is that hydroxychloroquine at 28 days did not increase virus clearance, but may shorten the time of symptoms. Similarly, their mean day from disease onset to randomization was pretty late on, and a majority received a concomitant medication or antiviral. And they do overstate their results, even those without statistical significance. They mention a significant decrease in CRP in the hydroxychloroquine group, although unfortunately, this really wasn't clinically significant. And then similar with the shortening and the time of symptoms, this was only in a subgroup of patients that didn't receive antivirals, and this was a very small proportion of the patients. So we have all of this information, and what do we take from this? So as of today, so far what our information has shown us is that overall there hasn't appeared to be much of a clinical difference. And when there is a clinical difference, there is some question regarding, how significant this would be in our patient population. And so at this time, if a benefit does exist, which I think we need better studies to demonstrate that, it is likely earlier on in the disease process, as the majority of the studies that showed a difference were those that were receiving it for fairly mild disease. It's always important to remember that these treatments are not benign, and some of the data has shown that as well with QTC prolongation. And so the risk and benefit, as usual, must be assessed for every patient. And then the last thing I really wanted to mention was that we do provide an interim pharmacotherapy guidance document on the COVID-19 UK healthcare website for everyone's reference. And I won't go through this in detail, but it does provide guidance for those who are thinking of prescribing hydroxychloroquine or other agents, and provides information just on dosing and monitoring and things to be aware of. But at this time, prophylaxis is not recommended for healthcare workers or patients, and then treatment information is outlined there. And at this time, an infectious diseases consult is recommended. So with that, I'll go ahead and switch it on over to Ryan, and we will try and see if we can share our screens okay. Okay, Ryan.
All right, thanks everybody. So from here, I'm going to be talking about some of the other agents, most notably lopinavir, ritonavir. As you can see, the mechanism of action of lopinavir, ritonavir in just normal retroviral life cycles was seen to be potentially useful in the treatment of coronaviruses, given shared drug targets in chymotrypsin-like proteases. This was seen after the initial SARS and MERS. So this was fortunately studied very much anecdotally early on out of China. However, of all of the drugs, we do have a randomized controlled trial in the midst of all of this, non-peer-reviewed data. It was a large randomized controlled trial, including patients older than 18 with SARS-CoV-2 positive by PCR. They did exclude pregnant patients, and if patients were deemed not of best interest, and in patients with underlying liver abnormalities, patients were randomized to either standard of care at the time or standard of care plus lopinavir ritonavir for 14 days. The primary endpoint they looked at was time from randomization to clinical improvement or discharge from the hospital. They defined clinical improvement as time from randomization to improvement in two points on a 7-category ordinal scale. You'll see this scale again later on. And then secondary endpoints for things like duration of mechanical ventilation, duration of hospitalization, and other secondary endpoints that we would find meaningful. They didn't see any difference in baseline characteristics of the patients. They tend to be older, mostly male, which we tend to see, again, in severe cases here. Median time to symptom onset, I want to pay particular attention to this, was 13 days with a range of about 11 to 16. Many patients got systemic glucocorticoid therapy, but that didn't seem to be different between groups. And median time to clinical improvement wasn't really found to be much different between the two treatment arms. However, there was noted to be numerically lower mortality seen in this trial, but it was found to be non-statistically significant. ICU length of stay, interestingly, was shorter numerically, but again, not statistically significant. And then there was no time in difference in clinical deterioration as well. So they didn't conclude anything game-changing with the use of lopinavir ritonavir. And since its use and recommendations from the majority of our colleagues has since waned, though likely if potentially useful, it would be needed to be used much earlier on against the virus, as one of the critiques of this study was that it was very delayed in its use. They did note a high mortality rate of 22% in the patients that were enrolled in the trial. And again, their use of throat swabs versus other methods of testing was also discussed as a critique. Remdesivir is an investigational therapy that has gotten a lot of focus, especially in the news. It interferes with RNA-dependent RNA polymerases. It was initially developed to combat Ebola and studied in that disease state. However, was found to have broad-spectrum antiviral activity, including viruses in the coronavirus family, notably SARS and MERS, CoV-1, and now SARS-CoV-2. This is just a table if you want to nerd out for a moment, basically looking at in vitro potency as measured in chick cells. The CC50 is a measure of selectivity. So as you can see, very low EC50s versus very high CC50s, which is a measure of toxicity to human cells potentially, which makes it a very desirable treatment in the treatment of viral infection. In the initial phase 1 studies, this was a slide that I adapted from a colleague's presentation because there really wasn't much published outside of a World Health Organization flyer. A lot of patients were noted to have them specifically high, none were seen to be higher than grade 2. Most notably, which is why you saw and still continue to see exclusion criteria for AST, ALT abnormalities. Typically that onset was 5 to 25 days and typically resolved. There were some other adverse events that were noted in the clinical trial for Ebola. There is some initial concern with how it's formulated with a non-aqueous vehicle, which again, similar to voriconazole, might be why some of the renal function exclusion criteria are present. However, with the clinical trial being very prescriptive, otherwise may not necessarily pan out, as there's not been much data to support holding off using voriconazole in the treatment of a critically ill patient just because of the non-aqueous vehicle. However, similar to lopinavir/ritonavir, just in the last week, there was a paper published in the New England Journal of Medicine chronicling merely the use in compassionate use sense of 61 patients. 8 of those patients were excluded from the overall analysis, given that they lacked post-treatment data and 1 had a dosing error. So really, it was a report on 53 people. The only criteria that I saw was you had to have a positive SARS-CoV-19 PCR and either O2 saturations less than 94, which was similar to what the enrollment criteria were on the website at that time. Patients were given 200 milligrams times 1 on day 1, followed by 10 days with 100 milligrams, and combined with supportive care. They were followed for 28 days. However, I want to note that data was only collected through March 30th, and if you pay close attention, it seems that many of these patients may not have completed the full 28 days if you look at their timelines in one of the tables. Patients were enrolled throughout the world, with predominantly enrolled to the United States, Italy, and Japan. They were predominantly male, similar to the lopinavir/ritonavir study, and older. However, many more patients in this trial versus the lopinavir/ritonavir trial were receiving mechanical ventilation, with the median time from mechanical ventilation employment to the receipt of remdesivir being about 2 days. 4 of those patients were actually receiving ECMO, so a much sicker patient population than lopinavir/ritonavir, and the median duration of symptoms prior to the initiation of remdesivir is again 12 days, so a significant amount of time from onset to treatment. However, that did not differ between invasive and non-invasive ventilation. They did follow the patients for a median of 18 days, and so again, not many of the patients got to the full 28 days of follow-up. They did note about a 70% improvement for what it's worth. They quantified this mostly by their oxygen requirements, which I'll show you moving forward, and then discharge. And they did note about 25 of the patients that were started on remdesivir were discharged within the follow-up time frame, including about a quarter of the mechanically ventilated patients. This was an interesting table that it took me about 20 minutes to figure out how to read. To orient you to this, they orient the patients to their baseline oxygen status along the top, and then really saying, okay, how much better did they do? Did they progress to death? So for instance, they had 34 patients receiving mechanical or invasive oxygenation. 6 progressed to death. 9 remained in that category upon some evaluation, and many got better. However, again, they didn't really have a standardized approach to what constituted improvement in other meaningful outcomes. So this was again what we were kind of seeing reported. They did, however, have, as the New England Journal of Medicine typically does, really nice graphs that showed time to improvement, which again, keeping in mind this was a non-controlled trial, so we don't know how patients who didn't receive remdesivir would have done in a matched patient population. However, it is promising nonetheless to see that patients can get better with this therapy. They did report on adverse events. About 60% of patients overall reported them, typically associated with hepatic enzyme elevation, as was seen with the Ebola trial, as well as diarrhea, rash, renal impairment. 4 patients discontinued it, 1 because of worsening renal failure, which would exclude them, and 1 because of multi-organ failure, and 2 because of elevated aminotransferases. There are ongoing clinical trials, which is the only way you can get remdesivir at the present time. They have closed down the expanded access program to include requests to only pregnant women or children less than 18 with severe COVID symptoms. There are 2 studies being headed up by Gilead that you can see there, 1 by the Army and 2 out of China. Another drug that's getting a lot of press is tocilizumab. It is an immunomodulating drug. And this is really, if you can't treat the virus, what we really want to do is treat the inflammatory problems that come with viral infection. I include this page just to show mechanism of action, but basically what happens is when you have normal IL-6 or pro-inflammatory cytokine, you're able to clear that. If you have an immune response, that IL-6 starts to become excessive and it evokes inflammation in other tissues, not just your immune cells, which causes a widespread pro-inflammatory state. So after tocilizumab therapy, which really binds to both soluble and membrane-bound IL-6 receptors, it doesn't stop the production of IL-6 necessarily, but it stops the downstream effects of this. So you extinguish the inflammation, you somewhat starve the immune system, and then you somewhat return to somewhat of a homeostasis. That's why this drug has been employed in rheumatic diseases, rheumatoid arthritis for years, and recently in CAR T-cell transplant. Now, this is because we're treating this cytokine storm. Now, as seen with previous SARS-CoV-1 and MERS, pro-inflammatory states mediated by these cytokines has been noted. You can see here this study looked at GM-CSF and IL-6, which were found to be markedly elevated in ICU versus non-ICU versus healthy control patients. So again, if we can't treat the virus itself, we could potentially stop the pro-inflammatory ramifications. This was one of the initial studies out of China. This was 21 patients enrolled for 2 centers. They really didn't have restrictive inclusion criteria. You just had to meet either the severe or critical criteria listed here. And they gave a flat dose of tocilizumab, 400 milligrams, followed by repeat dosing if necessary, and treated per the standard of care. At that time was the 6th interim edition for the treatment of coronavirus in China. 17 out of the patients were severe and 4 were critical of note. Only 2 were receiving mechanical ventilation and 1 was receiving non-invasive ventilation. But all of the patients were requiring oxygen supplementation as per the criteria. And what they really found after the administration of tocilizumab with about 3 or 4 patients requiring a second dose was a rapid resolution of pro-inflammatory markers such as CRP. Temperature returned to within the normal range very rapidly, as well as the oxygen supplementation and saturation. Of note, CT scan lesions were known to have been absorbed, whatever that means. I assume it means improvement. And then many of the patients were noted to have been discharged about 2 weeks post-treatment. And they found that their conclusions were that tocilizumab is an effective treatment of COVID-19 related inflammation and potentially useful. A second trial, which was done, included 15 patients whom received tocilizumab between the end of January and early March. Similarly, this study did not necessarily look at clinical outcomes, looked at IL-6 and CRP responses, but they similarly gave no really guidance on dosing. So you saw dosing on a very wide scale. They did allow repeat doses. However, they also allowed the use of concomitant methylprednisolone. They enrolled 15 people. They didn't really talk about what constituted moderately versus seriously versus critically ill. But they found that 9 patients experienced stabilization, 1 patient improved, and 2 had disease aggravation. Now this was, if you look really closely in the tables, they saw this, 3 patients overall died. What they saw similarly was that some patients, the CRP went down. This is a table showing all 15 patients with the CRP at baseline, and then their CRP kinetics over the next few days, and then their associated clinical outcome, which was again very vague. You will notice that IL-6, as we saw with the bathtub model, didn't really diminish in patients, even in patients that had soft clinical stability, because again, it probably will go up given that you need the IL-6 receptor to clear the actual cytokine. Their conclusions was that it appears to be effective. However, I found that it wasn't very descriptive, and then again, just lends the, to us to take it into consideration, but see it for what it is a report that didn't really tie meaningful clinical data to the use of a drug in the treatment of the disease. I think there's some safety issues that come up more notably in chronic dosing in rheumatoid arthritis, where they do tend to see more risk of infection versus the one-time doses that we may see. It remains to be seen whether this will be an issue. However, it is in the box labeling to monitor for the development of infection, particularly mycobacterial infections. And then again, the Canadian labeling does include monitoring for liver function abnormalities. There is a clinical trial being sponsored in the United States by Roche There's also one in China, one in Italy. There are similar clinical trials being initiated for mechanistically similar IL-6 inhibitors, as well as other immunomodulating agents, and I have those listed there. I think the unanswered questions, which a working group at the University of Kentucky is trying to solve is, if this therapy is as good as touted, whom should receive it, when and where, what dose should we give? Because again, going back to the studies you saw, they use flat doses, which again, from an anthropometric standpoint, our patients may be dissimilar in size and shape from the patients included in the trial because they really didn't comment on that. We also need to balance the needs of our CAR T-cell patients versus the SARS-CoV-2 patients because those patients will still need that therapy in the setting of the pandemic. And then we don't really know the risk of infection and also cost. Here in the United States, those drugs are very, very costly, and we just really don't know long-term how that will pan out. So again, I'm going to turn this over to my colleague, Dr. Porterfield, to finish up. I appreciate everybody listening to me. Thanks.
Yeah, and thanks for the opportunity to speak. So I'm going to talk about a couple of topics, including convalescent plasma, other experimental therapies, and then how do we apply this to patient care, and what is the role of research at the University of Kentucky. So just a very brief background. So I'm a physician scientist. I'm a virologist by training, appointed in immunology and also as an infectious disease clinician in the ID department, and I do a lot of global health work and clinical research. I'm involved in the COVID-19 response team in a number of different ways, including the development of clinical management algorithms, some planning for outpatients, and then developing some of the research trials that are ongoing, and the Research Alliance group that advises on UK's response to the COVID-19 research program. So just briefly, this has been described before, but I think this is a very interesting and helpful way to think about COVID-19 clinically. So it looks like, based on existing research, that there's an early viral response phase. So this is when viremia is peaking and the patient may be asymptomatic or developing symptoms. And then later on, there's a host inflammatory phase. And I will move relatively quickly through these slides, but just to sort of discuss that there may be some mild constitutional symptoms early on, and then you have a development of a more severe decompensation in certain cases, occasionally leading to ARDS and shock. But that the virus may actually decrease, and the actual amount of viral load may decrease before you get to the ARDS, SIRS, shock, cardiac failure picture, and the treatments may be very different. So if we're looking at abortive medicines or preventative medicines, probably early administration makes a lot of sense, and it may be a very different suite of treatments that we use in the host inflammatory phase. So here at the bottom are some potential therapies as an example of that, but we'll discuss in a little bit more detail. So thinking about convalescent plasma, so the basic idea is that you have a donor who is recovered from COVID-19, and in their body they have SARS-CoV-2 neutralizing antibodies. These are then donated to an AVO-compatible individual who is in need of antibody, and that these antibodies are relatively neutralizing. So some data exists for this. So in prior studies, so before SARS-CoV-2, this has been used to treat viral lower respiratory tract infections. Also, monoclonal antibodies have been used to prevent hospitalizations in some high-risk populations. So in '98, the Impact RSV study group did demonstrate that this was helpful in prevention of RSV acquisition in premature infants, so less than 35 weeks, and those with bronchopulmonary dysplasia. 2003, Feltes also demonstrated that RSV acquisition could be abrogated with convalescent plasma in patients who had hemodynamically significant congenital heart disease. There are some risks to using convalescent plasma. One, of course, is the transfusion-related acute lung injury or TRALI. And theoretically, there are examples of antibody-dependent enhancement of infections. The idea is that you have an antibody that you're giving to a patient which binds the virus, but then also the crystallizable fragment of that antibody is bound by cells. And sometimes this can co-localize virus with cells and actually increase infection. So this has been seen in MERS as a possibility. And so it is something to be thinking about, that there is a promise for this therapy, but perhaps mindful of the amount of data. I'm going to go through some data slides relatively quickly and show the primary data. I think it's worth looking at exactly how many data points there are. So when we're thinking about, is this a reasonable therapy at this point? What is the risk and benefit? Just thinking about how extensively it's been studied. So for instance, in SARS-CoV-1, so this is 2003, so not the current pandemic, human monoclonal antibodies were used as prophylaxis in a ferret model. And it was shown that when you use monoclonal antibody in 4 ferrets, it did seem to reduce replication by about 3.3 logs compared to a control. Sort of more visually, this is interesting, it did seem to completely prevent SARS-CoV-induced macroscopic lung pathology. So this is the lung of a ferret who was not protected, and what we're seeing are areas of necrosis and damage related to the SARS infection, and that this percentage of lung surface affected was essentially, or was 0 in the patients, or in the ferrets who received monoclonal antibody. There have been some additional studies looking at convalescent plasma in treatment of severe acute respiratory infections. These are viral infections, so this is not prophylaxis and prevention of acquisition, but actually use in severe SARS-CoV, influenza A, avian influenza, and Spanish influenza. And so this is a weighted forest plot showing that there is some protective effect overall, but most of these studies are relatively small in terms of numbers. So, but the idea exists, has been studied in some cases. So far, the data for use in SARS-CoV-2 is very limited. So there's a trial of 5 patients and a trial of 10. So in JAMA communication of 5 critically ill patients who were confirmed SARS-CoV-2 and had ARDS, who were treated with high binding, high neutralizing titer plasma that was given 10 to 22 days post-admission, so relatively late and probably out of the viral phase and into the host immune response phase. They did see clinical improvement in all cases. So 4 patients resolved their ARDS, 3 patients were weaned from the vent. And then just looking at some overall measures, and I apologize, some of the text is small here, but the cycle threshold, or the amount of virus, decreases over time. The SOFA score, which is a measure of sort of ICU 6-organ status, decreases. The partial pressure of oxygen over the inspired oxygen increases, and body temperature goes down. It's notable that these are, relatively, there is some noise in this measurement, and we're looking at, 5 individuals. The general trend is towards improvement, but it's also tricky to say what is the best timing of use of convalescent plasma. Does it matter when we give this? And almost certainly it does. And then, what is the time frame of resolution? Would these patients have gotten better irrespective, or was this an effective convalescent plasma? The second study, we looked at 10 patients with confirmed SARS-CoV-2, again with a high neutralizing titer of plasma that was given in a mean about 16.5 days after admission. It was also given in addition to antivirals, which is a bit of a confounder. But here, looking at some labs, again, clinical status tended to improve. CRP tended to go down. Lymphocyte count was a little bit low, may have normalized a touch. Oxygen improved. Liver function may be slightly down. But again, these are not, knock it out of the park type measurements. And so this is obviously a very heterogeneous population that we're catching at different times in their disease process. And it's important to keep in mind that we haven't yet defined when the ideal time to give convalescent plasma would be, and really nailed down if it has a beneficial effect. So moving through to other experimental therapies, there are quite a few of these, everything from reports that famotidine, H2 blocker, may be helpful in prevention of acquisition, and really repurposing any number of drugs. So University of Kentucky, the Dean Kip Guy out of pharmacy is leading a team looking at what is the evidence behind all of these other experimental therapies, and really evaluating, what can we do here at the University of Kentucky in terms of research and testing that would add something to the mix of thousands of research groups and universities around the world that are moving things forward. And I do think there are some important ways that we can contribute. I'm going to highlight a couple of experimental therapies, looking specifically at one called Camistat mesylate. So we know that SARS and SARS-CoV-2 use ACE2 as an attachment receptor. They also have a spike protein, and the spike protein has to be primed by cleavage before the virus can enter the cell. The implicated protease is this TMPRSS2, which is transmembrane protease serine 2 precursor. It is a human serine protease, so it's a human enzyme as opposed to a viral enzyme, and it does prime the spike. There's been some nice data. This is just a very quick visual in Vero E6 cells, which are permissive of viral infection. We showed that if we express TMPRSS2 in these cells, you have, even at high dilutions, effective entry of the virus into cells. This is a GFP reporter, so cells that are green are cells that are infected. And so certainly we know that TMPRSS2 is an enzyme that can work to improve the ability of the virus to get into the cells. Vocamostat mesylate is a potent inhibitor of serine proteases. It specifically inhibits TMPRSS2. It has been approved for clinical trials in the United States, and it's been used in Japan since the 1980s for acute on chronic pancreatitis and postoperative reflux. It has been shown, this is a Cell report out of Germany recently, that use of Camostat does decrease entry of pseudotype viruses. So these are viruses that, again, have a GFP marker so we can follow their entry into the cells. And it shows that Camostat at different doses does decrease cell entry in primary human airway epithelial cells. This has also been studied in some other ways. And so interestingly, it was given to cystic fibrosis patients on some early data that shows that it decreases or it interferes with epithelial sodium pumps and can change the potential difference within the nasal epithelium and the airway epithelia. And this is thought to increase mucociliary clearance. So as an interesting side mechanism, it may not only have a direct antiviral effect, but may also increase the clearance of the virus through this mechanism. This is done in cystic fibrosis patients. Again, only 9 subjects, so the safety data in sort of aerosolized or nasal administration is relatively limited. Interesting, this is a paper that was just published out of our group in South Africa, just showing which cells are implicated in infection. And so this is some T-distributed stochastic neighbor embedding or TSNE plots. And really what this does is it takes, and based on gene expression, groups cells based on the kinds of genes that they're expressing. So this is a group that is type 2 pneumocytes, and these are ciliated cells. This is expression of ACE2, and this is expression of TMPRSS2 overlaid on that. And you'll see essentially some dark spots really only in the type 2 pneumocytes and and the ciliated cells. But the idea that medication or delivering Camostat to these 2 cells may be important, and this may implicate infection both in the lungs and in the airway passages. Additionally, I'm going to talk about ivermectin, and there's a reason to the madness here. So we're looking at drugs that maybe haven't been in the literature or haven't been discussed much in the news just yet. So ivermectin is something that has been shown to have increased in vitro activity against influenza, equine encephalitis, and West Nile, presumably through a nuclear import mechanism implicating important alpha beta 1. And in SARS-CoV-2, it has been shown to have some in vitro activity with an IC50 of about 2 micromolar. Now, notably, ivermectin is used as an antiparasitic, so the highest dose that we use tends to be for lice. And one of the questions is, this is a relatively high IC50, and the dosing strategy that we use for parasitic effects tends to have a sub-nanomolar type effect. And so looking to see if when we translate this to an in vivo model, will it actually have an antiviral effect? But certainly there's a mechanism here that's promising, or at least an effect that's promising. So now thinking about application to patient care and research, and essentially there's one key slide, I think, to summarize this. And so this is the recent Infectious Disease Society of America guidelines on treatment and management of patients with COVID-19. They only highlight a few of the studies for which there's more data. And so hydroxychloroquine, azithromycin versus no treatment, Kaletra, or also lopinavir, ritonavir, corticosteroids without and with ARDS, and tocilizumab, and then convalescent plasma. Essentially, all of these are recommended only in the context of a clinical trial, except for corticosteroids without ARDS, where they suggest against use. And really, everything here is a knowledge gap. So this is a little underwhelming, and I realize as a clinician, this doesn't do a lot to help with decision-making, but the real point is that we're still in a phase that we are learning every day about this infection and how best to treat it. So a big take-home message, which I'll get to on my last slide, is really working through research is going to be critical. So just looking at some of the clinical trials and studies at UK, I'll talk about the top 2 at the moment, which are ones that I'm most keenly involved in, and then some other things, but we'll look at povidone iodine intranasal for prophylaxis in frontline physicians inpatients, which my colleague named PIPI, and then an adaptive multi-arm phase 2 trial of novel agents, which represents a collaboration between Markey Cancer Center, infectious disease, internal medicine, the hospitalist service, and CCTS, so a pretty broad and encompassing collaboration among really, really smart people here at UK to test some of these drugs and these novel combinations in some powerful ways. We're also looking at development of in-house serology, platelet coagulation dysfunction. We do have a convalescent plasma registry, and we can talk more about that offline. Things are still developing where we are able to offer convalescent plasma to patients. At the moment, Kentucky Blood Bank has the ability to take donations and store donations. And the current status is that if a donor comes from the University of Kentucky and identifies as such when they donate, University of Kentucky can request that plasmid. And so we're looking at refining that. We do have a registry which is looking at patient characteristics that's IRB approved at University of Kentucky to try and start sifting through who would be the ideal people to receive, or what are the characteristics of individuals that we think should receive convalescent plasma. We have a research registry and specimen bank that's been specifically set up to help us fund basic and clinical science on COVID-19 research, and then the PEDAL trial, which is being run in the intensive care unit, looking at hydroxychloroquine in late stage disease, which is also running. And this doesn't, of course, this is just a snapshot of certainly all the many, many projects that are going on across the university. Just very quickly, povidone, the PIPI trial. So we know that topical preparations of povidone iodine, which is a very well tolerated application, has broad spectrum bacterial, fungal, and antiviral effect. We use it already to decolonize for MRSA. It's got a great safety profile. We know it's effective against SARS-CoV-1 and MERS-CoV. The idea is that we're using targeting providers who are caring for COVID-19 patients and high-risk patients who are either negative or have not been tested. And the idea is to look and see if this nasal spray and oral rinse will prevent infection. So I'll give a blast out from my email at the moment, but we will be enrolling in this very, very quickly. If people are interested, we're looking for recruitment of patients who we're expecting to have a prolonged hospital stay of 7 days or more, and then also providers who care for COVID-19 patients. So if people are interested, certainly do get in contact with us. Second trial that I'll highlight is this adaptive multi-arm phase 2 trial of novel agents. So we've started with a design called Pick the Winner trial design. And so we're looking at 4 different arms: hydroxychloroquine, azithromycin, as well as hydroxychloroquine alone. This is serving as a backbone and a comparator because so many universities and institutions are running this trial. We would love to have the data to suggest how our other trials rate against it. We'll be looking at ivermectin, which I discussed briefly, and then Camostat plus HCQ as a phase 1 run-in. And we have a backup trial looking at Camostat and potentially ivermectin as individual agents in a phase 2 trial. The beauty of this is that there's a relatively rapid turnaround, interim analysis, and as these treatments fail or are found to be futile in terms of endpoint, they can be replaced relatively quickly with a new drug. We're looking at some very unusual agents at this point. In fact, we are the only institution at this point who's secured in the United States who secured a stash of Camostat for trial purposes. That will change, but for the moment we are running the first trial in the United States. There's one in Denmark, one in Germany, and one in Israel. But this is certainly something that UK will add to the mix for a number of reasons, but we were the best site in the nation for this trial. Just looking at a couple of additional interesting things. So this is a very complicated diagram that I don't expect people to assess in detail, but essentially we are restructuring our telehealth organization, and this is one possible way this may come together. I want to call everyone's attention to a couple of things. So essentially at the top, we're looking at patients who are tested, and at the bottom is the need for a face-to-face visit and or an ED visit. So one thing I'll draw attention to is what's called the get well loop, and there are much prettier versions of how this works, but this is an automated patient health monitoring tool. So patients who are tested at UK, there's a batch report that's pulled twice a day, and they're contacted and sent an email or potentially a text to enroll in this. It sends them a questionnaire every day and keeps track and can trigger red and yellow alerts and also identify when patients have questions. We also have numerous telehealth organizations at the moment out of different clinics, and we're trying to centralize those into one particular unit that can, if the automated loop has identifies somebody who has a question or needs additional evaluation, or if patients don't enroll in the Get Well loop but otherwise have questions or we're worried about them at home, we have a mechanism to evaluate them and consult with some of our specialists and then identify if they need a face-to-face visit. This is really important, and in fact, the big take-home message at the moment, and I apologize for going so rapidly, is much of what we need to do at this moment in terms of defining the proper treatments for COVID-19 is enrolling our patients in research. So IDSA, WHO, FDA, numerous organizations are suggesting we don't have enough data to recommend a treatment one way or the other, and that most treatments are being recommended in the context of a clinical trial. So this is a brief schematic of how patients might come to research, and so we are working to designate research clinics. So the infectious disease clinic and Bluegrass Care Clinic is one that will be research compatible, but essentially patients can walk in and get excellent COVID-19 care there, or and when they walk in, they can be consented for research. But it may be that either patients in the emergency department or being discharged from the hospital, or who are identified by other telehealth means, can be asked if they're interested in participating in research, and then directed towards a research clinic. So, watch this space at the moment. We will, advertise the best way to assist with recruitment, but we really are leaning heavily on our colleagues across UK healthcare to help us identify patients who might meet multiple research trial criteria and get them enrolled so that we can do the best we can in sort of adding to the picture of how do we best treat COVID-19. So I will stop with that. I will quickly say that my email address is zach.porterfield@uky.edu. If people have specific questions about research, I'm happy to take those, and I'll write that in the chat box as well. But thank you for the time and the opportunity.
All right, I think I'm going to read you guys some questions out of the Q&A section. What is the status of ongoing RCT on, it says chloroquines. I presume they mean chloroquines.
Do you mean in terms of like the clinical trials that are available at this time?
I would interpret it that way.
Yeah.
Yes.
So I didn't mention that in my portion of the talk, but there are numerous ongoing studies looking at chloroquine and hydroxychloroquine. I honestly am not 100% confident if many of the chloroquine studies are going on within the United States or just elsewhere. But ever since the study discussing the better in vitro activity of hydroxychloroquine versus chloroquine was published, along with our knowledge that hydroxychloroquine has a lower adverse effect profile, a lot of the research has more shifted in that direction.
Please comment on the importance of pharmacologic VTE prophylaxis. As noted, these patients are high risk.
Yeah, so that was a question that was brought up by Dr. Davis. I think, what we've seen in terms of discussion with some of our cardiology colleagues is that trauma-based dosing of 30 to 40 milligrams twice daily has been what's most discussed. I will admit that there was just so much stuff we couldn't really talk about all of it. And honestly, I think George will probably troll me for this. You could easily say that I have no idea what I'm talking about if I start talking about VT prophylaxis. So I think, it's definitely a burgeoning area, just as with the antivirals as well, but one that's just as important.
How does azithromycin help in COVID infection? Does it really work?
So anyone else can take this, I think, but we don't actually know at this point. So that's one of the reasons that so many of the trials are going on around the world at the moment. It may be that it has an effect on autophagy. It may just be that it's an anti-inflammatory property. It could be that there's some yet unidentified antiviral mechanism. So really, we're looking, as Katie presented, on some very small data that it did have an effect in 6 patients in combination with hydroxychloroquine, but that answer isn't totally available yet.
I have a question about how do you identify who's in the early phase, as many of them are asymptomatic or have very mild disease at that point?
It's a really great question, and it's a tricky thing to do. So obviously there's a vast majority of patients who are going to be fine, mildly symptomatic, may stay at home, may never know that they were infected. And probably the drug targets for that population is going to be less important. Certainly we would love to prevent transmission and test and treat everyone we can. A lot of the research that's being done is in the higher risk individuals, so folks who are over the age of 65 or have a comorbidity that's been associated with risk for progressive disease. But we're looking at patients who tend to be symptomatic, but before they've developed those severe host inflammatory responses. So early things to really look at that WHO and CDC are recommending are fever, shortness of breath, and cough as the major indicators, and then certainly other things like loss of taste, loss of smell. And there's a bunch of clinical work that's being done to identify the predictors of disease early on. But we're looking at that transition before they become severely decompensated.
All right, so this is one that caught the interest of the pediatrician. Is there any role of using pulmonary surfactant to help with COVID-19, especially if there's underlying pulmonary disease?
So I'm happy to take that one as well, but Katie, Ryan, please jump in at any point. So certainly the underpinnings of, how do we manage the severe disease? How do we manage the pulmonary decompensation is something that we haven't really figured out, but there's, individuals looking at treatment with things like acetazolamide, which would be used for HAPE or high altitude pulmonary. I forget what the E is for at this point, which is embarrassing in front of 600 people. But we're looking at how do we, is there an oxygen transport issue? Is there some, are we having certainly in the cytokine storm phase of the illness, the alveolar interface is compromised, and whether that's just debris or edema or any number of mechanisms. So I think it's a fantastic question and remains to be seen at this point.
Will this presentation be on CE Central this weekend? This one's for me. Yes, it will. We'll take it down by Monday so that none of this has time to get too outdated. Are there any thoughts about the role of statin therapy?
I can try and take that question. I mean, honestly, I had looked into some of this prior to this presentation, and similar to, I think, a lot of the other experimental therapies, there just really wasn't enough information to really put it into this presentation. I think a lot of it is, again, going back to anti-inflammatory properties. So at this time, I didn't feel there was sufficient information to really comment or provide a recommendation or standpoint for recommending statin therapies for that sole purpose.
The next question is, some hospitals in New York are giving therapeutic anticoagulation, especially when the D-dimer is elevated due to concerns for a component of microthrombosis. What do you guys think about that?
So I'll give another plug for a study that's being done at the University of Kentucky. So Wally Whitehart, Beth Garvey, and I have been working on platelet and coagulation dysfunction in viral infection. So we started looking at HIV, then COVID-19 has hit, and there's actually some indications that viral infection across the board can dysregulate these processes. And so we have an ongoing study that through the clinical trials that we'll be running, we will be recruiting patients for sample donation to really understand that in more detail. At the moment, certainly we do see that there are problems with the coagulation cascade, development of DIC, and any number of other problems that occur in severe illness. And it's not clear at this point if that's a direct virus effect or if it's just people get so sick that everything falls apart. But certainly at UK, that's one of the things that we're doing that is unique in the nation. I don't think that we have a clear recommendation just yet from any body in terms of whether that is an indicated thing to do. And so we'll watch from some of our smart hematology colleagues and other advisory groups to help us make those decisions. Certainly it is being done in places like up in Connecticut and New York.
We had a couple of questions about different vitamin supplements, vitamin D3, zinc supplementation, and vitamin C.
I mean, Katie's taken a couple of them. I tried to answer one of these on the Q&A. I know I've seen anecdotal reports where groups are using high-dose vitamin C or zinc supplementation. I know that there were some data on zinc in the outpatient basis for use for suppression of antiviral activity. Unfortunately, the dosage formulations that are available don't have high enough zinc concentrations, as well as some danger of intranasal formulations of zinc. I am not aware of any data that demonstrates the efficacy of zinc and or high-dose vitamin C in the treatment of COVID specifically, so I don't know that I can speak to that in terms of clinical use. So I don't know if it would be beneficial ultimately.
And there was a question asking if you could highlight some of the limitations of case series used, when you described the case series for tocilizumab, convalescent plasma, and so forth.
Yeah. Oh, sorry, Dr. Porter.
No, Ryan, you go ahead.
I mean, this is my opinion. Case series are what I was often taught as a student and a resident, reporting bias. So you did something, it looks okay, so why not report on it? I think that that's why we kind of, in an ideal world, would like everything to be a randomized controlled trial, but unfortunately, we're in an environment where we really can't do that. That was, again, one of the other questions in terms of why don't we have more data? Well, these trials take a little while to enroll and then also analyze and then publish. And I think that that's an important feature of the data that's coming out. And I want to stress to the group that you should really take the data that you're using and applying clinically and really evaluate it, because oftentimes what you're probably reading is not peer reviewed. So it's not undergone the scientific rigor that you stressed for your entire career, and that's a problem, at least to me. And I think that it's important that we remember that when we're caring for the patients. And granted, I know that there's not a lot out there, but I think that it's important to remember a case series is a case series, a case report is a case report. So if I do something 21 times and it works, I'm going to publish on it. But if I do something 21 times and it doesn't work, I'm less likely to report on it because it's not necessarily going to garner me a glowing publication. I want to make that clear.
Is anybody using cycle threshold or viral load to elucidate if a patient is ill from viremia versus aberrant host inflammatory response? Because it might determine the timing of the use of antivirals versus immunomodulators.
So again, that's a really nice point. And we certainly along the course of infection and in the trials that we're designing, we are looking at the level of virus at multiple time points, and several groups are doing this. And we do see that the virus level does tend to drop off often before you develop the severe symptoms. I don't know that it's been predictive at this point. Certainly the data is not deep enough for that, but looking at cycle threshold is going to be an important next step. There's also questions about what are the effects of medications and trial medications that we're using on resolving PCR and that sort of temporal shift in virus level. It's a great point, and I think that at some point, that plus maybe some biomarkers may be a good way of determining people's risks for progression to severe disease.
We had a couple of questions about Camostat. One being, are there concerns about sourcing it and for adequate use? And then is there data about achieving adequate blood levels, or is there a parenteral version?
So no parenteral version that is routinely used. This has been prescribed in Japan for 40 years, and they've got excellent safety data. The dosage that they use is 200 milligrams 3 times a day for for acute on chronic pancreatitis. We presume that this is going to be significant enough for antiviral effect, and that looks relatively good based on the in vitro data that we have so far. Sourcing and supplying it, this is something that appears to be routinely available in Japan. We've secured supply through a pharmaceutical company that's donating for our study. And my understanding is that they have another 1 million tabs on the way from Japan relatively soon for a multi-center trial. It is a small molecule. It doesn't, as not a physical chemist, I'm not sure about how easy it would be to scale up and manufacture, but at the moment, that's not a limiting concern.
I had a question about the use of statins in Singulair.
Honestly, I think my answer is probably similar to what I said about statins. I know even less about the use of Singulair for this indication, and I feel like the data that I have seen is comparable or is less so than what we've seen for statins. And so in general, I don't know that we can provide a general recommendation for that one either, but I'm also just not as knowledgeable about use of Singulair for a COVID-19 indication.
There's a question here about more questions about clotting. There was a recent pathology report from Louisiana of 4 patients that died from COVID that reported pulmonary microthrombi, and one institution was trying TPA. Are there trials looking at anticoagulation, thrombolytics, or bringing back Xigris from the grave?
So to my point about leaning on our colleagues, I just got an email from Jeremy Wood talking about there actually are COVID-19 guidelines from the American Society of Hematology and the International Society of Hemostasis and Thrombosis, which are recommending heparin treatment in ICU patients, except at those at significant risk for bleeding. I'm certain that there are going to be trials that are ongoing looking at preventing those complications, but at the moment, it's not something that is well understood.
There was one that just commented on altitude sickness, and I think maybe there have been some discussions around whether some of the injury mimics. I think that might be what that question was about. Any comments there?
So there's been some discussion about using acetazolamide for treatment because of the similarities between the 2 disease processes. It's theoretical at the moment, and what is the underlying, is there a difference in terms of what's driving the inflammatory phase in COVID-19 versus in altitude sickness? I would suspect that there are, but certainly it's a bit out of my area of expertise. But there are people who are definitely thinking through that, and other treatments like methylene blue to just sort of look at oxygen exchange.
There's a question about plasma donation. How much, when, and how often?
So an excellent question. I will have to probably get some exact details from our, so it's Kentucky Blood Bank, who is the partner that's storing the plasma at the moment. So I would refer to their website for the moment because I don't have that. I don't want to give wrong information at this point, but Kentucky Blood Bank would be the individuals that are have the permission to store the plasma and use it.
Okay, we're getting a bunch of questions again about zinc being used as a prophylaxis, the mechanism of action. I know you covered that briefly. Are there any additional zinc comments?
So I want to take a moment to comment. There was something in the chat from Dr. Bissell that they can donate 800 mils via apheresis, usually no more often than once per month. To the point about zinc as prophylaxis, again, I'm not, we barely have any data to demonstrate prophylaxis and or treatment with the current therapies for the actual disease state. I do not know of any data for zinc in the prophylaxis or treatment of COVID specifically. I would have to defer to the data as they emerge on that, because I'm just not aware.
Is there an infrastructure supporting the use of interactive web response service to do screening for trial participation, given the multiple options in scale-up phase here?
So I'll admit ignorance about the exact nature of interactive web response service, but certainly we are looking at using things like the Get Well Loop, which is this automated patient management tool for outpatients, which is already launched and running at UK, as well as our telehealth mechanisms to screen into research. But I will certainly I'd welcome a discussion about how we might use that to our advantage, because I think that would be, trying to find as many patients as we can and enroll them if they're willing would be a huge step in the right direction.
And then there were a couple of folks here asking about BCG and whether we're doing trials here at UK or elsewhere.
I did, unfortunately, I missed the, is this BCG I would imagine it's the TB vaccine.
So that's how I interpreted it. Yeah.
Okay. So not something that I'm currently aware of is going on at UK. As I mentioned, one of my other hats is working in South Africa, where I'm intermittently stationed and have a second lab. And we have the largest HIV population in the world, and probably the highest incidence of TB in the world. So those are studies that we're interested in looking at, what is the risk of, prior TB in terms of disease progression, or HIV in terms of disease progression. I haven't seen much of a discussion about BCG being a therapy for prevention, but again, I'd be happy if somebody has some information on that, or they'd like to shoot it my way, please feel free.
Does the donated convalescent plasma undergo routine testing for HIV and hepatitis prior to transfusion?
Yeah, so it would go through all routine screening at Kentucky Blood Center.
What about stem cell therapy? Anybody doing that?
So it's an interesting question, and I'm sort of thinking about, would this be for treatment of very, very severe disease? Certainly not. I think for prophylaxis, in that case the treatment would be more dangerous than the disease in most cases. There's nothing, it certainly is used in ARDS. I think it's early to understand how similar the pulmonary compromise that's induced by COVID-19 is to ARDS. I imagine there will certainly be people who are looking at this, and there's some possibilities of doing targeted T-cell therapy towards virus and virally infected cells. We do have a group out of microbiology, immunology, and molecular genetics who's looking at phenotyping the T-cells in the patients that we are recruiting. And so another sort of recruitment tool, sending patients to us, really helps us collect as much as we possibly can to understand this disease at all levels.
And then we have another question about HCQ and azithromycin. How serious is the risk of combining these medicines related to the risk of prolonged QT? How many adverse effects, deaths, those kinds of things?
Honestly, I think given that we're more unsure about the mechanism of azithromycin in combination with hydroxychloroquine, that's why our guideline tends to focus more on just considerations for hydroxychloroquine utilization, because there is the concern of potentiation of QTC prolongation with the combination. There was, and I can't remember the exact information, but there was actually, it was non-peer reviewed, a recent publication in the last few days, just looking at patients in general who had QTC prolongation and were prescribed either just hydroxychloroquine alone versus hydroxychloroquine with azithromycin or something like Augmentin, just from a database of patients. And they did find significant increases in QT prolongation. So I think that, you know, we really have to consider what would be the benefit of adding on azithromycin versus just using hydroxychloroquine, depending on the specific patient.
And I can add to that. One of our colleagues posted on the chat that said in Louisville they were seeing about 30% QT prolongation, about 500 milliseconds with the combination, typically about 48 to 72 hours after starting it. To comment to Dr. Wallace's point, that trial that was published did use a larger dose of hydroxychloroquine, as she said, but they noted about 20% of patients had a QT prolongation with chloroquine. Versus about 10% of patients in the lower dose group. So it's not infrequently encountered as some might tell you on social media posts is what I've been seeing. So it's definitely, these drugs are definitely not benign and should be monitored. And again, I don't know that azithromycin is adding very much. I just don't think we know enough at the moment once for the study.
So this is largely a pharmacy talk. So this last question I'm going to mention is one you can feel free to punt because it's about intubation. There's been growing evidence that intubation is not optimal for all patients. How are we drawing the line between ARDS patients needing intubation and patients with low oxygen saturations but otherwise not in distress?
I think I might take the punt on that one. There's certainly some incredibly smart pulmonologists who would be better equipped, but you know, I think it is interesting to know that there could be differences between this disease process and ARDS, and that we need more information to really understand the best management.
Okay. So I think that's it. You have managed to keep 272 people still on the webinar 20 minutes after the talk was over. So congratulations on a fabulous talk.
Thank you so much for having us.
Thank you.
Absolutely.